We're going to open the afternoon with a presentation evaluating clinical pathways for ovarian cancer treatment and maintenance therapy, sponsored as an educational activity by an educational grant from AstraZeneca and Tesaro. This presentation is presented by Dr. Susan Campos. Dr. Campos is Assistant Professor of Medicine at Harvard Medical School and with Dana-Farber Cancer Institute. Join me, please, in welcoming Dr. Campos.
Thank you very much for inviting me. This is actually very exciting. I've had the opportunity to be actually part of the clinical pathway at Dana-Farber, and it's actually been an incredible learning experience. You think it's easy when it's in your head until you have to put it on paper, and it becomes a bit more challenging. What I'm going to do today is actually take you through some incredibly inviting, exciting times in ovarian cancer. I'll tell you a little story. I'm old enough to have been in the room when they presented the data with Herceptin in breast cancer. Was anybody in the room when they presented that data? It was chilling, wasn't it? Wait till you see some of these slides. You'll feel the same way, okay? So here we go. So these are so I don't go to jail, okay? These are my consulting agreements. So what are some of the learning objectives that we hope to, what I want to share with you at the end of this day, okay? I really want to tell you a little bit about recurrent ovarian cancer and what the burdens of a recurrent ovarian cancer and why we're so focused in on remission in ovarian cancer. The other aspect that I'd like to discuss with you is what about clinical pathway implementation? How does one go about organizing a clinical pathway? I'm going to talk a little bit about being a BRCA1, BRCA2 mutational state, okay? What does the term BRCNAS mean, synthetic lethality? And what are the differences between some of these very new, exciting drugs called the PARP inhibitors? And then lastly, we're going to talk about clinical data and some recommendations for strategies for optimal integration of the PARP inhibitors into everyday clinical practice. When we talk about clinical pathways, I think one thing to remember about clinical pathways, as I know all of you know, is that it's not the result of just one individual or one discipline. In our group in the ovarian cancer world, the GYN surgical oncologists are extremely important. There's been data over data suggesting that patients who present to an institution should truly be seen by a gynecological surgical oncologist because the surgery is absolutely very, very important. It actually dictates what happens either before or after chemotherapy. Obviously, the medical oncology team, and that is the medical oncologist, the nurse practitioners, the physician's assistants, genetic counselors, very important in our world today because they will tell us if the patient is a BRCA1, BRCA2 carrier, or if they carry another, perhaps, deficiency in proteins that make up the homologous recombination pathway. Our pathologist will highlight whether this represents a high-grade serous tumor, an endometrioid tumor, or perhaps a low-grade, because that will help differentiate in terms of how you treat these individuals. Social work is extremely important, and the patient is extremely important. As we're starting to talk about oral formulations of drug, adherence to this medication is exceptionally important. So clinical pathways really do not involve one discipline only, but really it is a composite score of many different individuals. So what is really the role of clinical pathways? And we're going to go through this a little by little, but really at the end of the day, you want to deliver good quality care. And that's the end of the day, that's what you hope for every patient with ovarian cancer. And by really thinking out the choices that you have and managing these choices, the patients will actually be able to receive more choices at the end of their, during the course of their treatment. So very, very important. Quality of care is what clinical pathways derives. So let me take you through some of the challenges in ovarian cancer. Why is ovarian cancer perhaps a little bit different? Number one, unlike other disciplines, okay, we have no effective screening tool for ovarian cancer. And regrettably, women with ovarian cancer often present late. They present with stage 3 and 4 disease. And this really actually highlights why we have such a high rate of relapse and regrettably mortality. The other thing that we just mentioned previously is that ovarian cancer is not one disease. It's a very heterogeneous disease. You can have a high-grade serous carcinoma, an endometrioid carcinoma, a clear cell carcinoma, a mucinous carcinoma, carcinosarcoma, or a completely different type of uterine cancer called low-grade serous carcinoma. Many years ago, we would just lump all of these into one, and really over the course of the years, we've learned that really the high-grade and the low-grade are really two separate diseases, okay? And regrettably, despite the fact that we have looked at many different drugs in ovarian cancer in terms of upfront management, different schedules, intraperitoneal chemotherapy, at the end of the day, the backbone of ovarian cancer remains a platinum as well as an taxane. A couple of years ago, as you can see in this slide, there was two very pivotal trials. That was GOG 218 and ICON 7. Both of these trials asked a very important question. If you take the backbone of chemotherapy, which is the platinum and the taxane, and you add a third drug, this third drug was not a cytotoxic chemotherapy, but a biological therapeutic. It was a monoclonal antibody to the vascular endothelial growth factor, is bevacizumab. The question is whether or not you could improve progression-free survival in women in upfront ovarian cancer, and more importantly, overall survival. And the results of these two studies, both GOG 218 and ICON 7, in the general population, improved progression-free survival, but did not improve overall survival, okay? In high-risk individuals, patients that were not suboptimally debulked, patients that had stage 4 disease, there was an advantage in the ICON 7 for survival. So it really kind of still leaves us with a gap. Women who present to us with stage 3 and 4 disease, despite all the advances that we think we have made over the course of the last 10 years, we have still not improved overall survival in terms of upfront therapy. So there's a huge priority in this group of individuals. Now, so the elephant in the room for most patients with ovarian cancer is relapse. Because although we do an excellent job of putting people into remission, 70 to 80% of individuals will undergo remission, but 70% of those individuals will relapse. And the question really is when they relapse. Do they relapse less than 6 months after the completion of chemotherapy, or do they relapse after 6 months? That is extremely important. I'm going to take you through basically just a pathway in terms of how we think about this. This is a slide about the FDA-approved drugs for ovarian cancer. It dates back to 1960, almost to the current day, okay? And as you can see, in the 1960s, it was a bit sparse, and it's getting very crowded in our world right now in 2018. With this information at hand, with many chemotherapeutics available to us, including biological therapeutics and some of the drugs that we're going to discuss, how do we navigate the course of an individual with ovarian cancer so that they logically receive everything they can at any given time? It's very important in terms of how you weave therapy so that at the end of the day, they always receive as many options as they possibly can. So let's start from the beginning. Recurrent ovarian cancer. Where do you go from this? In your mind, in our mind, what we do is we divide these folks into two categories. They either are platinum sensitive, meaning what? Meaning that they relapsed after 6 months of receiving therapy, or they're platinum resistant, suggesting that, and meaning that, they've relapsed less than 6 months. And as you go forward, then you have an algorithm in your head in terms of how you approach these individuals. If you are platinum sensitive, okay, then we revert back to a platinum doublet plus bevacizumab, or a platinum doublet followed by a PARP inhibitor. I'm going to spend a little bit of time talking about this. If, in essence, the patient is platinum resistant, recurring disease less than 6 months, we focus on many different things, but one particular thing that we focus on is bevacizumab plus chemotherapy, but we also focus on the PARP inhibitor, of course, based on whether they carry a germline or a somatic mutation. I think it's very important to also, I'm highlighting the basic nature of this, but we always look for a clinical trial, regardless if the patient is platinum sensitive or if the patient is platinum resistant. So that's quite important. But at the start, this is how we navigate our thought process when we're treating patients with ovarian cancer. So let's take and step back for 2 seconds and talk about platinum-sensitive disease and what's the role of bevacizumab. There are 2 trials that actually were key trials. One trial, the very first graph, is the OCEANS trial, and the second trial is GOG 213. In both of these trials, in platinum-sensitive recurrent disease, the investigators looked at basic chemotherapy. In the first trial, the OCEANS trial, it was carboplatin, gemcitabine, and bevacizumab. The authors of the study, Akajanian and colleagues, actually reported that there was a progression-free survival benefit with the use of bevacizumab with chemotherapy and as maintenance therapy. GOG 213 was actually published by Rob Coleman just recently, and once again they asked many questions, but they asked the same questions. If, in essence, you were to add bevacizumab to that of chemotherapy, could you improve progression-free survival? And if you gave the Avastin, bevacizumab, as maintenance, could you improve progression-free survival as well as overall survival? In GOG 213, there was a progression-free survival benefit, and they hit the overall survival at exactly 0.05. So one option in patients that are platinum sensitive but have recurrent disease is a carboplatin doublet plus bevacizumab. So that is an option, and we lean on both of these trials to address that, the OCEANS trial as well as GOG 213. What happens if the patient is platinum resistant? I think one of the key trials actually published in Journal of Clinical Oncology were the results of the Aurelia trial. And the Aurelia trial actually looked and asked a very basic question. In patients with platinum-resistant disease, if you combine bevacizumab with chemotherapy versus just chemotherapy, do you improve progression-free survival? And the answer is yes. So navigating the course of women with ovarian cancer, platinum-sensitive, platinum doublets, bevacizumab, or if platinum-resistant, bevacizumab plus chemotherapy. That's just a nice way to actually, a little algorithm in our head to actually take it forward. But what about the PARP inhibitors? We've entered an era of PARP inhibition. And the question really is, okay, how do you select patients for PARP drugs, and how do you decide when to actually treat these individuals? And it's a very important question. PARP inhibition in ovarian cancer, have we found a possible Achilles heel? And I think we have. So let me take you down the road of PARP inhibition. When we talk about PARP inhibitors, we really talk about what they actually influence. And they really are important in patients who have a homologous recombination defect. Mutations happen all the time. Single-stranded mutations happen all the time. The PARP inhibitors repair the PARPs repair the single-stranded breaks by a base excision repair. If you block a PARP inhibitor, then what happens, if in case you have a normal cell, they can repair your DNA just fine. If, however, you have a cell that has homologous recombination deficiency, the cell dies. So it's a double whammy. This is the beauty of PARP inhibitors in patients with homologous recombination defect. Now, over the course of the last several years, we asked ourselves the question, does the patient have a BRCA mutation, or does the patient not have a BRCA mutation? But in the last couple of years, we've learned that high-grade ovarian cancer patients can actually be classified into three categories. You can have a wild type. You could be negative for a BRCA1, BRCA2 mutation. You could carry the mutation BRCA1 and BRCA2, but somewhere in between, having the mutation and not having mutation are a group of individuals who actually do respond to PARP inhibitors. They may have a deficiency in another protein that may not be BRCA1 or BRCA2, but is also a very important component of the homologous recombination. We call them BRCA-like. And this has been exceptionally important in maintenance therapy in patients with ovarian cancer. So if we go back a couple of years, we ask ourselves the question, the PARP inhibitors. What is the data that surrounds the PARP inhibitors in patients with ovarian cancer? And this is not maintenance, just treatment for patients with ovarian cancer. And there have been several studies. Now, there are now there are many drugs, but there are three major drugs that have actually been looked at. One of them is called olaparib, and that was studied in about 137 patients, and the authors reported an objective response rate of about 34%. The median duration of response in this study was 7.9 months. In another study, a rucaparib study, was actually a joining of two different studies, but as a result of Ariel 2, they studied about 106 patients. These patients had greater than 2 prior lines of therapy. There was a 54% response rate in patients with ovarian cancer. In patients with platinum-sensitive disease, it was about 66%, but also in patients with resistant disease, it was about 25%. Niraparib was studied in a very smaller study, although it's now been studied in the Quadra study. In this particular slide, 20 patients were evaluated, 40% objective response rate. If we were looking at platinum-sensitive disease, it was about 50%, platinum-resistant about 33%, but a median duration of about 12.9 months. These drugs have added tremendously to the benefit of women with ovarian cancer. As it stands now, olaparib is approved as a single agent for patients that carry a germline mutation if they received three prior lines. Rucaparib, on the other hand, is approved for patients with less than 2 prior lines, less than or equal to 2 prior lines, who carry either a somatic or a germline mutation. Okay? That's important. Single agent therapy in patients with ovarian cancer. But I told you a very important thing early on. I told you that we do a very good job of putting people into remission with ovarian cancer, but we do a very poor job of keeping people in remission. So the goal of therapy is maintenance therapy. Can we improve progression-free survival in women with ovarian cancer? So over the course of years, many investigators have looked at other drugs in terms of keeping women in remission, anything from some forms of immunotherapy to certain cytotoxic chemotherapies. But at the end of the day, what are the requirements for maintenance therapy? It has to work. It has to be effective. If it's a chronic course, it has to have minimal toxicity, and it has to be convenient. Maintenance PARP inhibitors in ovarian cancer. What I'm about to do is actually walk you through some very pivotal data in terms of PARP inhibitors and how this has changed women's course with ovarian cancer. So there are 4 trials that you should be aware of, okay? There's the NOVA trial that used niraparib. There's the SOLO2 trial, which studied olaparib. There's a Study 19 study, which used olaparib. And there's the Ariel 3 data, which used rucaparib, okay? First, you have to start learning how to pronounce these. This is the hardest part, okay? So the very first study is called the NOVA study, okay? And this NOVA study was a maintenance study. It was a phase 3 study. And in this particular case, patients that had platinum-sensitive, recurrent, high-grade serous carcinoma were treated with a carboplatin doublet. They then asked the question, do these individuals carry a germline mutation? And if they did, they went into one category. And if they didn't, they went into the non-germline BRCA mutation. So you got the division between germline and non-germline. So there was about 350 patients in the non-germline, and there was about 203 patients in the germline mutation carriers. These folks, okay, were then randomized to either niraparib at 300 milligrams q.day or placebo, okay, those 2 categories. And then they were followed. The primary endpoint of this study was progression-free survival. They were followed till progression of disease. These were the results of the NOVA study. If you specifically look at the germline mutation carriers, you see that these curves actually separate very early on. The hazard ratio is 0.27, and this was a statistically significant benefit in terms of median progression-free survival with the use of niraparib in germline mutation carriers. We all expected that. It's a PARP inhibitor with a BRCA mutation carrier. In contrast, if you take the other category, if you look at niraparib in non-germline BRCA mutation carriers, they looked at HRD. HRD is homologous recombination deficiency. They tested that with a myriad test. It was a composite score. They looked at patients that had no germline mutation but still had an HRD deficiency. And once again, there was a statistically significant benefit with the use of a PARP inhibitor in this category. They then looked at the other category, no germline mutation, no HRD, and in that category also, using niraparib as maintenance therapy improved median progression-free survival. I think it is important to note that if you look at the benefit across all groups, there is a difference of magnitude across the germline and the non-germline HRD and the group as a whole. But overall, the use of a PARP inhibitor improved progression-free survival in patients with ovarian cancer. FDA approved this particular drug for all patients with platinum-sensitive disease who've responded to a platinum therapy. In a likewise fashion, the SOLO2 trial was a bit of a different trial. This particular trial used the PARP inhibitor called olaparib. And in this particular case, they looked at patients that were platinum sensitive, as did the NOVA, and they enrolled these patients and then subsequently, in a 2-to-1 fashion, randomized them to either olaparib or placebo. And as you can see, in the SOLO2 trial, using olaparib, when you look at median progression-free survival was indeed improved by the use of a PARP inhibitor, in this case, germline mutation carriers only. Now, Liederman and colleagues actually took a look at patients, all comers, okay, and treated these individuals with olaparib as maintenance therapy. So they could have been germline mutation carriers, they could have been non-germline mutation carriers. And as you can see in this particular slide, in the Study 19, patients were randomized to olaparib or placebo. You'll see the difference in milligram dosages. The studies were different because at the point in time in this study, we had a capsule formation of olaparib, so it's 400 milligrams twice a day. Once again, what you can see from this particular study is that all patients actually benefited from the use of a PARP inhibitor as maintenance therapy. So you have the NOVA data with niraparib, you have SOLO2, and you have the Study 19, the latter two with olaparib. All of them are showing you the exact same thing. Not to be undone is the third study, the rucaparib study. And this is the Ariel 3 data. Once again, very similar design, okay? Platinum-sensitive disease, high-grade serous or endometrioid, and patients were randomized, in this case, in a 2-to-1 fashion, to a different PARP inhibitor, rucaparib versus that of placebo. And as you can see by the curves, all patients benefited from the use of rucaparib as maintenance therapy. Once again, patients that carried either germline mutation carrier or a somatic mutation carrier benefited the most, but all comers benefit overall. This actually changed the course of women with ovarian cancer, women that have platinum-sensitive recurrent disease who respond to a platinum-based chemotherapy. They can be put on a PARP inhibitor. They can be put on niraparib, they can be put on olaparib or rucaparib, of which all of them had a median progression-free survival benefit. So, as it stands now, the PARP inhibitors are approved. I told you about olaparib being approved in germline mutation carriers, patients who've had 3 or more prior lines of therapy as a single agent. Olaparib is also approved as maintenance therapy as part of SOLO 2 and Study 19. Rucaparib, on the other hand, is approved if patients had less than or equal to 2 prior lines as a single agent with patients with somatic or germline mutations. It's also approved as maintenance therapy. And niraparib, at this point in time, is approved as maintenance therapy, once again, in platinum-sensitive ovarian cancer. So when we're talking about clinical pathways, I showed you that divergence of platinum-sensitive. A very key component here right now is a platinum doublet followed by a PARP inhibitor. Now, with the enthusiasm that comes with the PARP inhibitors, we always have to balance our enthusiasm with the potential side effects, because at the end of the day, every drug has a side effect. And all of these drugs, they all have their unique side effects, but in essence, they're really a class effect. You do actually see hematological toxicity. You see anemia. You can see thrombocytopenia. You can have GI toxicity. You can have some nausea. You can have some gastritis. You can have taste disturbances. Very importantly, as has been reported, although it's about 2% only, if not less, myelotoxicity in the terms of perhaps a pre-leukemic state like MDS and leukemia. So you do have to advise patients. There is no apparent toxicity in germline mutation carriers. So I think we have to balance the enthusiasm for these drugs. We have to be mindful in terms of the potential side effects of these drugs. But in essence, you finesse these drugs every single day, especially when you know that they can indeed improve median progression-free survival. Okay? That is this is actually a slide that I think is actually quite important, and we have to be cognizant of this. These drugs do cost money. So if you take a look at olaparib, a cost of 28 days of therapy is about $16,000. That's an APW value. Rucaparib, about $17,000, and niraparib, about $23,000. So we must be mindful of the cost of these drugs when we are implementing them in a pathway. Now, I began this talk by telling you that we could use bevacizumab as maintenance therapy, or we can use a PARP inhibitor. So how do you, as a clinician, when you're designing a clinical trial or designing a clinical pathway, how do you navigate the course with these women? Well, you tailor the treatment to the person that sits before you. If a patient presents to you with recurrent disease, perhaps platinum-sensitive disease, but has a lot of ascites and is not a BRCA mutation carrier, you might lean more towards a bevacizumab. In contrast, if you have a patient that presents to you with recurrent disease that is platinum sensitive but has a germline or a somatic mutation, you know exactly which avenue, which pathway you're going to take. You're going down the PARP inhibitor pathway. So that's how we think about it in clinical practice. So I'm going to present to you a case, okay? This is a 48-year-old woman with stage 3C ovarian cancer, and she has a germline BRCA1, BRCA2 mutation. She undergoes primary debulking surgery and 6 cycles of chemotherapy with carboplatin and Taxol. She enters a complete remission. Regrettably, 1 year later, she develops CT evidence recurrence. What treatment regimen would you recommend, and would you recommend maintenance therapy based on what we've just talked about? So in designing a pathway, how would this actually look like? So take step by step by step, okay? Number 1, we know she's platinum sensitive. We know she has recurrent disease, okay? She's going to get chemotherapy with a platinum-based backbone. We also know that she's a BRCA mutation carrier, in this case, a BRCA mutation carrier that is a germline mutation. So she'll be treated with a carboplatin doublet, and you can choose carbotaxol, carbodoxil, carbogem. There's no difference among all of them. She achieves a complete response. Are you going to give her maintenance therapy? Yes, you are. And she's a germline mutation carrier, so you're going to introduce her to a PARP inhibitor. You can introduce her to niraparib as part of the NOVA data, olaparib as part of the SOLO2 or Study 19, or rucaparib as part of the ARIEL-3 data. That's an easy course. That was an easy question, okay? But this is how we navigate and this is how we design the pathway in our clinical practice. Now, I don't know if any of you have gone to ESMO this past week. I did not, okay? But my colleague actually sent me the information, and now it's all published in New England Journal of Medicine. And on October 20th, 2018, we had a little gift, okay? And this is a little gift that came down our way for ovarian cancer. I started this talk at asking who was in the room when the data from Genentech presented Herceptin in breast cancer. And it was a chilling event when you actually saw those curves. You changed the course of women with breast cancer that day. Welcome to SOLO-1, okay? SOLO-1 was an international study. It's double-blinded, randomized study of olaparib post first-line therapy in patients with the BRCA mutation state. And I told you that maintenance therapy worked, okay? I told you that they worked for platinum-sensitive recurrent disease. What if you were to put a drug like this up front in patients with ovarian cancer? So patients would be treated with the carboplatin in doublet, and these patients were randomized in a 2-to-1 fashion to either olaparib or placebo. And you can see the curve. If you can see it all the way back there, or in New Jersey, okay, you see that there is a difference in terms of median progression-free survival. The hazard ratio was 0.3. This is as chilling as it was when Herceptin was presented for metastatic breast cancer or for adjuvant therapy. This will change the course of women for ovarian cancer that at least has a germline mutation. ESMO, SOLO-1, Kathy Moore presented it, published in the New England Journal of Medicine this week. About 2.5 seconds after the presentation, actually, to be exact. Now, this is not the only study that is actually looking at a PARP inhibitor as upfront therapy, okay? So I want to walk you through some other studies that I think are important that may, in essence, answer some additional questions. There's a trial called GOG 3005, and that looks at chemotherapy plus a different PARP inhibitor plus a PARP inhibitor with maintenance. That is ongoing. We do not have data as of yet. There's a very interesting study that I think may, in essence, be quite instrumental. That's called the PAOLA-1 study. And the PAOLA-1 study actually looks at the backbone of chemotherapy with platinum and taxane, but then uses the combination of bevacizumab and olaparib as maintenance therapy. I began this talk by talking to you about Bev in terms of maintenance. I included PARPs in terms of maintenance. What if the two were put together? There is some preclinical evidence suggesting that the combination of an anti-angiogenic plus a PARP inhibitor is actually quite instrumental. That's being studied as maintenance therapy after first line. Now, the PRIMA study uses niraparib, but unlike the SOLO-1 data, actually did not restrict its eligibility only to germline or somatic mutation carriers. They're looking at not only a mutation carrier, but also the wild type to ask the same question: does a PARP inhibitor post-first-line therapy improve progression-free survival? So these are the studies actually to look for. We have striking data from SOLO-1. We look forward to GOG 3005, the PAOLA-1 study, and the PRIMA study. So what, at the end of the day, does clinical pathways do for us? At the end of the day, it reduces variability. I gave you a scheme to actually follow, and it promotes high-value care. It promotes quality of care, okay? And is this applicable for the PARP inhibitors? It absolutely is applicable for the PARP inhibitors. Listen, I want to leave you with one slide. First of all, any questions, please? Please.
So, Robin Zahn. So my question is, in our clinical practice, our geneticist is doing testing for homologous recombination deficient repair in those individuals who are BRCA1 or 2. We actually had patients who were positive. We put them on a PARP inhibitor and actually are getting good responses. So I was wondering about that. And then separate from that, we're also doing somatic testing. And so the germline may not be there, but we are finding incredibly more than I would ever expect, in terms of the cancer cells themselves expressing the BRCA1 or 2. And what is your experience with that?
No, it's exactly very similar. We would send all our patients to genetic counseling so we'd know whether they carried a germline mutation. But since the data with the ARIEL data, the ARIEL-2 data, we started to look for somatic mutations. It's been on the order of about 7%, actually about 7%. And that's exceedingly important, I think, now, especially in light of the SOLO-1 data, when it was both germline and somatic that improved so much. So exactly the same. It's about 7%. We are sending everybody off to test for somatic mutation. Absolutely. Question? I'll leave you one little note, because I love this. We have taken a huge leap forward in ovarian cancer. So thank you for listening, and I'll be happy to address any question that you might have. Thank you.